I am really excited that on our panel we have two pediatric cancer survivors. First of all, congratulations. We're glad that you're here with us. And I would like to start with the two of you, Brittany and Vicki, and have you describe to us, and you maybe Vicki first, your diagnosis and what was it that you needed from the medical community that you didn't get when you were in treatment 25 years ago, and then Vicki, for you, 12 years ago? You want to start, Vicki?
Yeah, sure. So I was diagnosed with acute lymphoblastic leukemia. I went through a fairly standard 2.5-year treatment protocol, which of course is still very similar to what children go through nowadays.
We have some pictures of you, right, when you were...
Sorry?
And we have pictures of you. There we go.
Oh, yes, there I am. Well, yeah, my fashion sense has improved somewhat. Arguably, I don't know. I don't have a water gun anymore, though, which is slightly disappointing. Anyway, yeah, so, I mean, first of all, so I was in hospital for a long time, and, pediatric treatment centers in the mid-1990s were possibly a little different to how they are now. I had several friends with brain tumors, especially, who did not survive, and, people passing away was not as rare as it is now. It's not rare, of course, but it definitely was more common then. And there were some incredible child life specialists who I remember very fondly, who really went out of their way to make sure that we were children still, despite our experiences, and we were able to go to school in the ward whilst growing up. But I really think there is still a gap in providing care for the families and the siblings of children with cancer. If I could change any one thing and advise people to do more, it would be this, because childhood cancer is not an experience which a single person goes through. It's an experience which the entire family goes through, and we still have a long way to go for providing for families and siblings especially.
Brittany, you were diagnosed when you were 13.
Yes.
And I know in the United States, especially 12 years ago, there were so many centers were set up for young children or adults. And there you are, an adolescent. And you don't fit in either world.
Absolutely. And unfortunately, still, there's a little bit of that dichotomy. I remember sitting on the pediatric floor, and there's clowns going around, and they're playing, and I'm, in high school trying to do my homework. And it's, and young adults have very different needs as well. You're worrying about dating, and you're at the age where you know exactly what's going on in your body. You understand how serious this is. And as you get older, you're concerned about fertility and other issues that I think aren't addressed right now. I think kind of you're getting to, okay, how can I get cured? And then the after is really very much ignored, especially for pediatric cancer patients that are hopefully living for many, many more years. We're not thinking about the long term and those late-term side effects.
Well, I just personally am excited that the prognosis is so much better now than it was when my best friend, Dorianne Frame, died of leukemia. It was many decades ago when the survival rates were less than 10%. And now for the disease that you had, it's over 90%. But what I did not understand, and I think so many people don't, is that though we have so many children now surviving cancers that, and Dr. Brawley, do you mind if I call you Otis, that there are so many children, 85%, who then by the age of 45 end up developing at least one other severe debilitating illness. Why is this happening? And when do doctors become aware of these late effects?
Yeah, please do call me Otis. Unfortunately, while we treat and cure, and it's rare that an oncologist can say cure in the adult setting, many of these kids, the treatments have tremendous side effects. We're talking about cardiovascular disease, sometimes stunted growth, some endocrine disorders. You mentioned fertility earlier. And then, of course, post-traumatic stress syndrome from going through the entire experience. And many childhood survivors will have 3 or 4 comorbid diseases, we call them. Early on, we started realizing in the 1960s, when we started being able to cure ALL, that within 5 to 10 years of a cure from ALL, there was a certain proportion, a small proportion of ALL survivors who would come back with a myelogenous leukemia. They got a second cancer from the first the cure from the first cancer. And so that was in the 60s and 70s. In the 1990s, we've had more of a palliative care movement in medicine, and that's where we've been really able to document the problems of survivorship. And these are problems that, as you said, we cause with the cure for the disease.
Did you realize when you were both in treatment that these late effects were even possible, or were you mostly aware that, well, maybe I might relapse?
No, I was completely unaware of any kind of late effects. I think, 25 years ago, the focus, possibly quite rightly, was still very much on we must successfully treat as many children as possible because, for my type of cancer, 25 years ago, for the precise type I had, it was about 65%. So it was still, fatal, not unusually fatal. And so I think I'm sure that people were aware to a point of what these treatments could cause in the future, but the focus was still very much on we need to cure as many children as possible. And I think, obviously we still need to work towards better treatments to cure children who can't successfully be treated, of which there are many, but there is an added kind of consideration now of, we need to cure these children, but at what cost? What happens to them in the future? And we absolutely need to, at the moment for a lot of these chemotherapy agents we use, there is no viable alternative. So we need to do two things. One, we need to learn how to manage these late effects in people who do experience them. We also need to eventually do over the whole treatment protocol to use kinder treatments.
And Brittany, you said you actually have some of these late effects.
Yes, so I experienced pretty severe chronic pain due to scarring and nerve damage from my surgery and radiation treatment that's down my arm. And, I felt a lot of times ignored sometimes, but also that for a pediatric patient, I don't want to be on strong pain medication for the rest of my life. And so trying to come up with other modalities and other coping mechanisms to deal with the chronic pain, but also feeling heard from a doctor that I shouldn't just be happy that I'm alive and that, oh, you can deal with this chronic pain because it's a better alternative. And so like Vicki mentioned, learning about those toxicities, trying to develop less toxic treatments moving forward is absolutely very paramount.
Now, Otis, you were with the American Cancer Society as their chief medical and science officer for almost 12 years. Do you think when we look at the medical community today, are they doing enough with their new treatments to make them less harmful in the long run? You wrote a book several years ago. Was it Do No Harm, correct?
How we do harm.
How we do harm. That's
Yeah.
it. How we do harm.
Yeah. We are starting to focus more on trying to look at the entire patient. And luckily, one of the things that we've learned in some of the leukemias, for example, is we can look at some genomic signatures and say, this is the type of leukemia that needs to be treated very aggressively, where we're perhaps going to have to accept some of these side effects or long-term side effects if we're successful. This is not a good leukemia, but a better leukemia, better behaving leukemia that's more likely to respond to our therapies. This patient does not need to be treated as aggressively and perhaps will not have as many of the side effects. But we still have, for all of these children, we've got to worry about the emotional effects of the treatment. We've got to worry about supporting the entire family, as was said earlier.
Ladies, I did introduce you earlier as cancer survivors, but I think perhaps cancer warriors is maybe a better description, because I think it's fascinating that both of you in your work today have taken on the diseases that impacted you. You are working to find cures, you're working to find causes. Why is that? Did you feel others weren't doing enough?
So for me, I think it came from this wanting to know more. I had fought this disease and, beat it in my own body and wanted to go out and beat it for others. And, I wanted to know how it worked and how it hijacked the normal machinery. And I just wanted to learn so much and impact others. And so I'm a thyroid cancer survivor and now thyroid cancer researcher. And I get to go into the operating room and see patients lying on the operating table like I was over 12 years. And just to know that hopefully the work that I'm doing in the lab will help to impact their lives and the lives of others. It's very rewarding personally for me, and I think as researchers it's also good to have that personal connection, to have that passion, to keep the big picture of why we're doing the research, that sample in a tube is not just patient number 432, that's a person.
And Vicki, I know as part of your work, you also really openly advocate that survivors like you be included in the process of deciding how we move forward with these treatments, that you have a voice.
Yeah, absolutely. I mean, we can learn a lot from both patients and survivors, and I think this is something which is kind of becoming an idea and a little bit more mainstream now. Patient advocates and survivor advocates are now invited to some big cancer conferences to kind of contribute and talk about their advocacy work. But we still have a long way to go. I mean,
And you've said survivor's guilt can get in the way, though, to patients speaking up.
So personally, that's not something which I've particularly experienced, but I do know that it's something which a lot of people do experience. For me, it was very much because I'm a scientist, I have a very scientific brain. I don't think there was any luck involved in me surviving. I think it was science. I happened to have the genetics of a leukemia that responded well to treatment, and here I am. Other people were not so fortunate. But survivor's guilt, and I know some other survivors and advocates who do struggle with that, and I think we all maybe we all channel it in different ways, as you were saying at the start. So I do what I do because I was always going to become a scientist from a very, very young age. I wanted to be an astronaut and a physicist, actually, and that kind of didn't happen. Maybe it will. But
time.
When I was on treatment, I asked all the doctors all these questions. Why am I getting that drug? Why is that drug red? And is it going to turn my pee red? The answer is yes. These questions. But I must have been an interesting patient from my medical team. But everyone was wonderful at answering my questions, and so that kind of funneled me into being a scientist. But there was a side effect that I had on treatment, which I won't go into because I'm in the interest of time. And then I actually ended up doing a research project, and we published 3 academic papers trying to find out why this side effect actually happened. And I basically did that because my mum said to me that was the most terrifying thing that happened to you on treatment. Has anyone worked it out yet? 20 years later, no. And so I assembled a small team and we actually looked at it. And so my question is, if me as a survivor turned scientist has this question, surely every survivor has a useful a question that we can do research on. But we're not asking people regularly, and we're not creating the spaces where they can contribute and actually tell us their ideas. So I would love to see that in the future.
Otis, before we go to questions from the audience, we now have nearly 500,000 pediatric cancer survivors. Is our healthcare system in the United States set up to give them the care that they will need throughout their lifetime? And as we know, talking about these late effects, they are likely going to need a lot more care.
The unfortunate short answer to that question is no. Medicine in the United States, or medicine in general, is not really prepared to take care of folks who have survived cancer and their side effects. This is true in adults as well as in the pediatric or childhood population, but it's especially a problem for childhood cancer survivors because many of them in their teen years have to transfer from pediatric oncologists who have taken really good care of them. And I must say the pediatric oncology community as a whole has been amazing just in how they've organized and taken care of people. But when the patients start seeing adult doctors, the adult doctors are just not prepared. They don't know what to expect. Unfortunately, we've just not been able to organize ourselves and have good teams of people who are responsible for taking care of survivors of childhood cancer.
So much to address. Well, let's go to our audience with questions. And
Hi there. Another question is, we talk about children and cancer. Well, the first question is, how do you define children? What is the age range? And then 2, for teenagers or adolescents, is there enough of a research and treatment on that? And the second question would be, hearing the perspective of the patient, are organizations, researchers really taking on your insight and those of your family to really improve the research, improve the methodologies of finding new cures? Thank you.
Let me tackle the first 2 questions. In terms of resources for cancer, I think there's not enough resources for all cancer. We're at a point in time where the National Institutes of Health is funding 10% of all the grants that are submitted to the NIH that the NIH think is good enough to be funded. I wonder what really good research has been ranked 14th or 15th percentile and didn't get into the top 10% that we're not funding. So it's all research. I don't want to get in the disease Olympics, as I see people pit breast cancer versus prostate cancer versus childhood cancer. And by the way, if we find something good in any cancer, it's actually going to have it's going to actually have implications for other diseases.
Otis, maybe we should let Vicki and Brittany speak up to the second question. And obviously you said you did have some results with your research. Are doctors listening to you and heeding your feedback on ways to proceed?
So I think things have improved dramatically in the last few years. As I said, major conferences are now inviting survivors and advocates, but there's an awful long way to go. Sometimes I personally feel that there's a lot of tokenism, like we need to have these patients or survivors involved to make us look good and to kind of tick a box. At major scientific conferences, there normally is not a lay summary of the proceedings. Patients and survivors often are extremely knowledgeable. They have done their reading, but still we don't necessarily make the information accessible to them. And these kind of efforts are still very few and far in between. There is not a lot of sort of systematic effort, I don't think, to consult survivors on research priorities. So I did a TED talk a couple of years ago on cancer survivors and why we should include them more in dictating research. And I asked a number of healthcare providers and survivors, what's important to you? What should researchers be doing? Now, the medical oncologists almost exclusively said cardiovascular problems and secondary cancers, so things that would reduce lifespan. And the survivors almost exclusively said mental health and fertility, so things which largely would increase the quality of life. So we have this big disconnect between what the medical oncologists and healthcare providers think is important and what survivors think is most important. And of course, everything is valid and needs to be researched, but we need to talk and decide what our priorities are, because unfortunately funding is not infinite.
Do you find that to be the case too, Brittany?
I do. I mean, the advocates are out there. Like, even with the National Cancer Institute, the Office of Advocacy Relations, the OAR, they can place advocates with researchers. It's just the researchers wanting to include those advocates. And I think from that perspective, almost having a top-bottom where on grants that you've shown that you've consulted with an advocate for fear of hopefully not going into tokenism, but just to make that extra requirement that there are advocates included, because as Vicki said, these advocates are very well trained. A lot of them are not representing, when I go as a patient advocate, I'm not just myself. I'm there on behalf of the community, and they're trained and part of organizations that they're coming and have a lot of valuable feedback and information.
Brittany, Vicki, Otis, I know we could go on and on, but we've run out of time. Thank you so much for your passion and your insights and your work on pediatric cancer that continues. Thank you.